A very good afternoon to one and all. Many scales have been reported which assess the feeding practices among children of various age groups. A systematic review by Vaughan et al. Has reported 70 parent feeding measures. However, there is a lack of conceptualization of structure-based feeding practices. Early childhood caries is a significant public health problem in developed as well as developing nations, with a prevalence of about 49.6% in India. Harris et al. Has reported 106 risk factors, a few of which are enamel defects, high levels of Streptococcus pneumococcus, and breastfeeding for over a year and at night, after the teeth have erupted, as reported in other systematic reviews. Accumulation of milk or other liquids or food substances on the tooth surface throughout the sleep time is a substantial causative factor in the occurrence of early childhood caries. There is a lack of exclusive study of sleep time feeding practices, for which a separate scale that focuses on this is necessary. With this in mind, myself, Akila Ganesh, I am going to present to you the development and validation of a scale to assess feeding and sleep time, in short the FeaST scale, among infants and toddlers. The aim of which was to construct and validate a robust scale for the comprehensive assessment of sleep time feeding practices. Ethical clearance was obtained and informed consent was obtained from all the participants involved in the study. These are the various phases of development which we'll be seeing in detail in due course. So first of all, a conceptual framework was formed from specific variables which were described in previous scales from a thorough literature search, existing knowledge and opinion of experts. And the various constructs were breastfeeding, bottle feeding, other feeding modes and tooth and diet construct. So an initial item pool was formed for each of these constructs where questions were framed as full sentences and double negatives, two-edged questions and slangs and abbreviations were avoided. As reported by Trackman et al. In 2017, certain redundancy was followed at this stage to retain questionable items which can be later removed in the process of development. So these were the number of items which were developed, which were 16, 18, 5 and 6 in the breastfeeding, bottle feeding, other feeding modes and tooth and diet construct respectively, leading to a total of 45 items. These 45 items were refined through a focus group discussion, cognitive interviewing and pre-testing. The focus group discussion was done on mothers, public health dentists, pediatricians and pediatric dentists, which was moderated by a moderator, and the participants were allowed to express their opinions and views freely. The answer options were discussed and modified, and the focus group discussion was video and audio recorded for further reference. So the initial 45 items were now refined to 28 items through the focus group discussion, which was now subjected to cognitive interviewing, which was done to test the response scale for its adequacy, relevance and understanding, to assess the comprehensiveness, clarity of the items, to generate new items or modify existing ones, and to eliminate any irrelevant items as well as to rephrase items. It was done on mothers, dentists, nurses and medical professionals by the Think Aloud protocol, where the question was asked and the subjects were allowed to think about it and give their opinion about the question and the response options. Next, a pre-testing was done when members of the target audience were interviewed for accurate capture of their vernacular. The primary rationale was to eliminate items that the participants perceived as unimportant, to increase data accuracy, to identify potential difficulties with the scale, and jargon and technical terms which were used with caution. These were the various recruitment sites for the subjects of the cognitive interviewing and the pre-testing. It included 2 healthcare facilities and a public and private medical center of our institution. So these besides the various steps in the refinement of item pool were 14 participants in the focus group discussion, 11 in the cognitive interviewing and 20 participants for the pre-testing. A validity testing was done by 5-member team who were subject experts who ascertained the face and content validity. They included public health dentists, pediatric dentists and pediatricians. The remarks obtained from the experts were consolidated and duly incorporated into the questionnaire after discussion with a senior professional. So these were the various items which were considered but eliminated later, added items and the modified items in each of the various stages of development. Finally, the scale was subjected to reliability testing through a test-retest method where it was initially tested on 57 mothers and after 10 to 14 days on 40 mothers. And an almost perfect agreement was obtained in 96% of the items with a kappa value of 0.81 to 1. So this describes the schematic development of the FeaST scale. So the initial items which were formed and which were subjected to focus group discussion, cognitive interviewing, pre-testing, validity testing, and finally reliability testing. The FeaST scale was developed and validated as a specific parent-reported measure. It is a new perspective which evaluates all dimensions of parental feeding behaviors concerning sleep time among infants and toddlers. Develis had said that the number of items included in the first draft of the scale must be 3 to 4 times the number that would appear in the finalized version. Thus, the initial item pool was developed with great caution so that no relevant details were missed. The strengths of our scale is we included a varied socioeconomic strata, a panel of experts were involved in the various steps of development, a variety of feeding constructs were measured, both solid and fluid intake associated with sleep were measured, and pre-testing and cognitive interviewing, which are considered as important steps in scale development, were a part of our scale development as well. However, the limitations are the generalizability of the scale is uncertain because it is not a community-based sample, and the possibility of social desirability bias could have also occurred. Finally, I would like to conclude by saying, though FeaST was primarily developed as a research tool, additional uses as a potential clinical scale can be suggested. It also facilitates further research into their role in the occurrence of ECC, and it needs to be tested globally. This has been published in the 2020 volume of the Community Dentistry and Oral Epidemiology Journal. These are my references. Finally, I would like to thank my mentor and guide, Dr. M.S. Muthu, who has been with me through the development of this scale and for having given me this opportunity to present it in this SECRI 2021. Thank you one and all.